Welcome everyone to the 6th International Health Sciences Conference Radiology session. My name is Mindaugas Brazdžiūnas and I will be leading this session today. First of all, on behalf of the Student Scientific Society of Lithuanian University of Health Sciences, I would like to thank you, our patrons, Fresenius Kabi, Roche, Medita, Orgmed, and others for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedical fields. We hope that this conference will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health with young scientific all over the world. Additionally, I would like to express gratitude for all of the reviewers and today's jury. Vaidas Palinauskas, Chairman of the Young Academy of the Lithuanian Academy of Sciences, Associate Professor Tomas Lapinskas, Member of the Young Academy of the Lithuanian Academy of Sciences, Associate Professor Donatas Vajauskas, and Professor Algidas Basevičius. We kindly ask jury members to remain at the session until the points are counted and the winner is announced. Before starting the session, I would like to remind you some rules. Today, we will hear 6 presentations. All of the presentations will be evaluated by the jury. Based on the average scores given by the jury, we will choose one winner from the section. The winner will get great awards from our sponsors. Gifts from Bioderma, Sapiens, Chrysostomus Bookstore, Orgmed, Gintarinė Vaistinė, Filman, and Medita. Winners will receive their gifts after the session. Furthermore, presentations should last no more than 7 minutes, and after that, 3 minutes will be dedicated for questions from the jury members and listeners. Please note that if your presentation will exceed 7 minutes time frame, you will be asked to go to the final slide and finish your presentation. I ask the jury to fit in the given time as well. Moreover, each presenter will receive a certificate that will be sent to their emails after the conference. Is there any more questions before we start? Okay then, best of luck to all the presenting authors. And now I would like to invite the first presenter, Ramona Matusevičiūtė, to give us the first presentation about the influence of angiographic factors on the treatment tactics of acute superior mesenteric artery occlusion.
So, good morning, everyone. My name is Ramona Matusevičiūtė, and I am delighted to start this year's conference's radiology session. And today, I'm going to present our study about the influence of angiographic factors on the treatment tactics of acute superior mesenteric artery occlusion. We conducted our study in the interventional radiology department, and our scientific supervisor was Dr. Rytis Stasys Kaupas. To begin with, acute superior mesenteric artery ischemia. Acute superior mesenteric artery occlusion is one of the most common causes of acute mesenteric ischemia. Although overall survival has been increasing, more than 60% of patients with acute SMA occlusion do not survive. According to recent European guidelines, endovascular therapy, or EVT, in most cases should be the initial approach. SMA occlusion can be caused by both atherosclerosis of the arteries and embolism. Therefore, the aim of our study was to assess the influence of different etiologies and the level of occlusion on treatment tactics when treating acute superior mesenteric artery occlusion. First of all, I would like to acknowledge that this retrospective study was approved by local ethics committee. We collected and analyzed medical data of patients presented to LSMU Kauno Klinikos from January 2018 to December 2020 with acute abdomen symptoms. The clinical diagnosis of acute SMA occlusion was established by triphasic contrast-enhanced computed tomography angiography, or CTA. We did not include patients with chronic, non-occlusive venous mesenteric ischemia and other rare causes of acute mesenteric ischemia. The total of 80 patients were diagnosed with acute SMA occlusion and underwent digital subtraction angiography, or DSA. Based on the findings of CTA and DSA, we classified all cases by the level and etiology of occlusion. Afterwards, patients went for EVT. Comparison to other similar studies conducted in the last 5 years, the amount of patients included in the study ranged to the maximum of 50, while we analyzed 80 patients. According to the CTA and DSA findings, we classified the level of occlusion according to the number of superior mesenteric artery large branches that remained non-occluded. Ostial occlusion, meaning 0 patent large branches. Proximal occlusion, meaning 1, 2, or 3 patent large branches, meaning inferior pancreaticoduodenal, middle colic, and jejunal arteries. And distal occlusion, meaning 4, 5, or 6 patent large branches, usually, additionally to those mentioned before, ileal, right colic, and ileocolic arteries. We also classified the etiology of the occlusion into thrombosis and embolism. Thrombotic etiology was defined as SMA and/or nearby aorta calcification on CTA and stenosis with adjacent thrombus on CTA and DSA. Embolism was determined where collateral circulation was poor or absent and round clot surrounded by contrast material or filling defect with an abrupt cutoff was observed. Also, data analysis was performed using SPSS statistics and p-values below 0.05 were considered as a statistically significant result. Therefore, thrombotic etiology was identified in 25% and embolic in 75% of patients. Ostial occlusion was present in 23%, proximal occlusion in 47%, and distal occlusion in 28% of patients. Thrombosis was associated with more proximal, meaning less patent large branches occlusion, while embolism was related to more distal occlusion, and this was a statistically significant result. Regarding demographic data, we noticed a tendency that thrombosis appeared more frequently in males, while embolism was more frequent in females. Also, patients with thrombosis were statistically significantly younger, while patients with embolism were older. In all cases of embolism, mechanical thrombectomy was the technique of choice, and 21% of embolism cases required secondary PTA or stenting. In case of thrombosis, EVT techniques dispersed equally. Half of patients received mechanical thrombectomy with subsequent PTA or stenting, while for the other half patients, PTA or stenting was the primary and only treatment performed. Thus, mechanical aspiration thrombectomy was performed statistically significantly more frequently when more non-occluded large branches were present, while PTA or stenting was performed in cases with fewer intact large branches, and this was a statistically significant result. Also, I'd like to mention that proximal SMA occlusion as well as embolic etiology occurred the most often in other similar studies as well. So, to conclude, the most common observed etiology was embolic. The most frequent SMA obstruction site was proximal occlusion. Mechanical aspiration thrombectomy was performed more frequently when more non-occluded large branches were present and etiology was embolic. PTA or stenting was performed more commonly in cases with fewer patent large branches and thrombotic etiology. Thank you.
Thank you very much. Are there any questions from the... No?
Thank you very much for a nice presentation. I would like to ask one question about the analyzed group of patients. You mentioned that there were 80 patients,
Yes.
but we didn't get information if there were, how many of them were women and men or age groups, because you mentioned also in the results that there were differences between the age groups. Could you
Yes.
comment on this?
Actually, we also analyzed our demographic data, but because of the presentation being pretty short, I had to include only the main factors of our study. As I can remember from demographic data, there were approximately 50-50 of men and women, and the age mediana was 81 years old.
And were there some differences between men and women? Or?
Yes, as I mentioned, we noticed a tendency that thrombosis appeared more frequently in males, while embolism was more frequent in females. However, this was not a statistically significant result, meaning it was not below 0.05 p-value. It was around 0.1, but it was a tendency. So in a bigger study, maybe it would show even bigger significance.
While you was collecting all the data, did you have a chance to look at the differences in risk factors or concomitant diseases between these two groups?
Yes, we also collected the data of comorbidities of those patients. The most common ones were atrial fibrillation and hypertension. And this was not something new, because in other similar studies in the last 10 years, we went through similar studies, and these results were also a tendency in those studies. Actually, atrial fibrillation being the number one comorbidity, affecting more than 50% of those patients, and probably contributing to the embolic etiology of this disease.
That's true, especially also looking at the drugs, if they have the anticoagulants, when they have the atrial fibrillation. So
Yes.
that might be a cause for the embolic events.
Yeah, actually, regarding this question, although 50%, more than 50% had atrial fibrillation, only 1/3 of those patients were taking anticoagulants regularly.
Indeed. Thank you very much.
Thank
so
you
we
for
can
your
move
question.
to another speaker.
Thank you.
Thank you, Ramona, for your presentation. And now I would like to ask the stage Dominykas Kaupas, who will present an overview of single-center experience in endovascular therapy for acute superior mesenteric artery occlusion.
Good morning. My name is Dominykas, and I'd like to present an overview of a study of a single-center experience in endovascular therapy for acute superior mesenteric artery occlusion. For a quick introduction, acute superior mesenteric artery occlusion is a life-threatening condition with a potentially high mortality rate. Despite constantly improving treatment and overall survival in recent years, perioperative mortality still varies between 31 and 62%. The aim of our study was to evaluate technical success, failures, complications, and intra-hospital mortality of endovascular therapy for acute SMA occlusion at the Hospital of Lithuanian University of Health Sciences Kauno Klinikos during the 3-year period from 2018 and 2020. So we retrospectively assessed medical data of 80 patients who, due to acute SMA occlusion, were presented to EVT. Regarding the evaluation of technical success, complete technical success was defined as restored flow to the SMA stem and all large branches. Restored stem flow with at least one large branch still occluded was assumed as a partial success, and a failure to restore blood flow in SMA stem was defined as a failure. We also calculated success rate by combining fully and partially successful cases. The central pie chart displays 3 endovascular treatment pathways that were registered. More than a half of all cases were managed by performing mechanical thrombectomy alone. 29% of cases were managed by mechanical thrombectomy with subsequent percutaneous transluminal angioplasty and in some cases stenting. And finally, PTA stenting as a primary and only technique was accounted for 12%. And the surrounding pie charts demonstrate the success rates for each endovascular technique, and they were 83, 69, and 90% accordingly. However, the difference was statistically insignificant. In general, 67% of cases were technically successful, 13% were partially successful, and 20% were a failure. Thus, the overall success rate of the treatment was 80%. Out of 16 cases which were a technical failure, in 7 cases, EVT failed due to long thromboembolic segments of the artery. In 5 cases, the reason for failure was unsuccessful access due to proximal SMA occlusion. And in 4 cases, difficult vascular anatomy was the main reason for a failure. There were 2 serious complications related to endovascular therapy, an inguinal hematoma, which was successfully treated conservatively. However, it prolonged patient's hospital stay, and one case of a perforated left common iliac artery, which evolved from a problematic access to the SMA and caused a massive bleeding. The bleeding was managed by stent implantation. Eventually, due to unspecified shock, the patient died on the same day. Overall mortality rate was 58.8%, and in case of a fully technically successful recanalization, almost half patients died, and in case of a failed recanalization, almost 9 out of every 10 patients died. Therefore, the more successful endovascular therapy was, the lower intra-hospital mortality rates were. To conclude with, our study revealed that the overall technical success rate was 80%. Failures occurred mostly due to complexity of the occlusion or difficult vascular anatomy, and the complications were rare, while intra-hospital mortality appeared to remain extremely high and to significantly depend on endovascular therapy's technical success. Thank you, and I'll be glad to answer your questions.
Thank you very much, Dominikas, for the elegant presentation. I have a few questions. First is regarding mortality rates in success group. It was quite high, 48%. Can you comment on that? And maybe you have some comparison with the other centers studies. And the other question would be, what was your personal contribution in this study?
Well, regarding the mortality rates, they are extremely high. Yeah, and as we can see, even when the procedure is successful, technically successful, the outcome is still not far from satisfying. And there's still a lot of research need to be done to further understand why is that so, and yeah, is that. And regarding my contribution, I personally, we both with my colleague actually collected all the data of the patients. We also evaluated the CTA and DSA findings, of course with the help of our scientific supervisor, and I did the statistical analysis of the data.
Okay, of course that would be interesting to look more at what are the reasons for the mortality. Maybe the patient arrived too late or procedure time was very, very long. So, but at the end, I think you can combine your results and move to the publishing the data, which is very important. Okay, Other.
Thank you for nice presentation. I have one short question. As you have an opportunity to look at the CTA data, were there any cases that you could say that from the CTA that angio procedure won't be successful or is going to be just partially successful? By means that maybe this patient should be skipped from the endovascular treatment and proceed further with the other kind of therapies. Have you looked at the CTA data? CT angio?
Yes, of course, we looked at it, and however, we did not find some findings that would indicate that the procedure would be unsuccessful, but well, maybe after our investigation, well, as I mentioned, the reasons for a failure were the difficult vascular anatomy, for example, the sinuosity of the artery, or a inconveniently angled SMA from the aorta. Well, these may be the indications for maybe a more difficult endovascular therapy. However, for now, all these patients go to EVT, and well, regarding the difficult anatomy, vascular anatomy, we discovered that maybe in some cases the more appropriate approach would be to exploit other axes rather than using the most common femoral axis. It may be useful to exploit the brachial axis in some cases. So yes, that's about that.
Thank you.
No more questions? Thank you.
Yes, the time is up, and sorry to inform, but we need to proceed to the next presentation.
Okay.
Yes, so thank you for being so curious about endovascular therapy. But now I would like to ask the stage Justina Speišytė, who will present a topic about assessing burnout in radiologists.
Okay, so hello everyone, I am Justana, and we did with Domantas Vingris and Inga Zaboriana work about assessing burnout in radiologists. So work-related burnout is a multifactorial syndrome which consists of three fundamental symptoms: emotional exhaustion, cynicism, and decreased professional efficacy. Recent studies suggest that burnout may erode professionalism, influence quality of care, and increase the risk for medical errors. So our aim was to examine the prevalence and associated factors of Okay, so our aim was to examine the prevalence and associated factors of professional burnout syndrome in radiologists. Methods was a 23-item anonymous survey, including 7 original questions and the 16-item scale MASCLAC burnout inventory general survey. BIGS was handed out to radiology doctors and resident doctors in Kaunas clinics. Original questions assessing risk factors included data on personal characteristics like age, gender, marital status, work experience, and workplace-related questions, satisfaction in salary, and work environment. MBIGS scale is divided into 3 subscales that measure work-related burnout, emotional exhaustion, cynicism, and professional efficacy. Burnout was measured in 5 profiles. Burnout was, which means high exhaustion, high cynicism, and low professional efficiency. Overextended, which means high exhaustion, ineffective, low professional efficacy. Disengage, high cynicism, and engage, which means low exhaustion, low cynicism, and high professional efficacy. The high and low means were calculated using mean values, and survey authors provided critical boundaries for profiles. All calculations were performed using SPSS and Microsoft Excel, and p-value less or equal to 0.05 was considered statistically significant. So our results were data of 71 respondents, including half doctors and half resident doctors. Mean age was 33 and a half with standard deviation 10.18. Average work experience was 8.5 years with standard deviation 8.94. 46.5% of all respondents were married. 48.6% of all respondents were satisfied with work environment, and only 27.8% were satisfied with salary. The burnout rate in study population was almost 20% of all, and 27% of all respondents felt overextended. 20% respondents were ineffective, 4% were disengaged, and 31% respondents were engaged. Among residents, the burnout rate was 25%, and among doctors, burnout rate was less, 14%. The incidence of overextend within the resident doctors was 25%, and within doctors, 28.6%. Within the residency duration, 2nd and 3rd year residents were most burned out. Lower satisfaction in work environment also associated with greater rate of burnout, which was statistically significant, and shorter work experience was found to be statistically significant within burnout respondents. No associations with gender and marital status among burnout profiles were found. And our conclusions that 20% of radiologists suffer from burnout syndrome and another 25% of them experience high exhaustion. Only a third of respondents were experiencing no symptoms of burnout, and factors such as work experience, salary, and work environment were significantly related to burnout syndrome.
Thank you very much for this presentation. I would like to thank for taking this important question, because the burnout it's really important in medical field. And my question first would be regarding sample size calculation, because the number of respondents is not very high. You think it was sufficient just to have statistically significant results?
We did only in Kaunas clinics, so but I think we need more respondents.
Also, I would like to have a question regarding survey. It was performed in English or Lithuanian?
It was translated to Lithuanian.
Because there is a risk for the validation. So you should take it into account when you just translating survey. Sometimes it's not enough, you need to validate the survey. And can you, after this study, because you see the problem is really significant,
Yes.
and there is a difference when you're comparing burnout between doctor specialists and doctor residents. Can you comment on that? What could be the reason for that?
Like work experience. I think the more years you are working, the less burnout.
So you're
maybe
coping with the stress?
Yeah, with stress, but in this work, it was related to work experience mostly.
Any other questions? Okay, plenty of questions.
Thank you all for your presentation. I would like to ask your personal opinion, which fundamental factor is most important? How do you think? Emotions or cynicism? Your opinion, your personal opinion.
Maybe professional efficacy, because it depends on patients, and if we have low professional efficacy, we have like bad results. And yeah.
I would like to ask also one question. How relevant is this problem in other countries? And maybe you found some results from other countries and you can compare about...
We talked with Domantas, and like we read it, radiologists have like a big problem in the whole world, and results is quite the same.
Okay, thank you.
Can you give recommendations for employer?
For what?
Because I'm as a provider and you are working in my company, can you give me recommendations how I could change environment just to feel you better?
Or, maybe work hours, maybe like in the whole company. I don't know.
Because here we're looking for the problems and we would like to make changes just to feel you better at work. So that could be a thing we could think about.
About workload.
Okay. Thank you.
Thank you, Justina, for your presentation. Thank you for the jury for your questions. And now I would like to ask Vaiva Cechanavičiūtė to present the added value of SPECT-CT over planar images of lung perfusion scintigraphy in the diagnosis of pulmonary embolism.
I cannot open it. Oh. So, good morning, everyone. I'm Vaiva Tsakhanovichuta, and today I will talk about pulmonary embolism and nuclear medicine methods. And I will present two presentations today. So, both of them, the results of both of them were gained investigating the same patient population, so information a little bit overlaps and complement each other. So the first topic is the added value of single photon emission computed tomography / computed tomography over planar images of lung perfusion scintigraphy in the diagnosis of pulmonary embolism. Me and my scientific advisor, Associate Professor Donatas Vajauskas, have chosen to investigate the patients with suspected pulmonary embolism because this condition carries a high risk for death. But if it's timely assessed, we can prescribe a treatment and avoid poor outcomes. And nuclear medicine imaging techniques are widely implemented for the evaluation of this condition. Lung perfusion scintigraphy is a very common method used in many medical centers, but there is one new modern method, which I mentioned before, single photon emission computed tomography / computed tomography, which showed the value in the diagnosis of pulmonary embolism. Why this method is very special? Because when we perform lung perfusion, we get information about physiological performance of respiratory system. But when we perform SPECT-CT, we have also the picture of anatomical condition of the lung. And this is why we aim to compare and assess the value in the diagnosis of pulmonary embolism and compare SPECT-CT and planar scintigraphy. So the methods were, we included 61 patients. All those patients were suspected of having pulmonary embolism, and this is why they were referred to the Department of Nuclear Medicine at the Hospital of Lithuanian University of Health Sciences, Kauno Klinikos. All those patients underwent lung perfusion scintigraphy and SPECT-CT, and we, of course, used gamma camera and used radio labeled injections, and also the aerosol that was inhaled also was labeled. And the results were, so out of 61 patients, 37 were females, but the gender predominance was not observed, and the median age was 68 years, and it shows us that the patients with suspected pulmonary embolism tend to be older, and pulmonary embolism was observed in 26 patients, accounting for 42.6%, and this prevalence was similar to the other studies. About those two methods. So the sensitivity and specificity for planar scintigraphy were 69.2 and 94.3. And SPECT-CT, as we expected, showed better sensitivity and specificity, and sensitivity was prominently higher in SPECT-CT, accounting for 96.2, and specificity was 100%. The prevalence of false positive and false negative results are also important because planar scintigraphy had the prevalence, higher prevalence of both of them, and it says us that planar scintigraphy tends to overdiagnose or underdiagnose pulmonary embolism, and SPECT-CT had false positive results for 0% and false negative for 2.8.
Positive predictive value and negative predictive value were also taken into consideration, and those two values were observed to be higher when we performed SPEC-CT. And overall accuracy of SPEC-CT compared to planar scintigraphy was higher, accounting for 98.4% versus 83.6%. So we have concluded that SPEC-CT has better diagnostic efficacy in the diagnosis of pulmonary embolism compared to planar scintigraphy. And as I mentioned before, that planar scintigraphy is widely implemented in medical centers. So based on our results, we conclude that we consider that in order to achieve the most accurate diagnosis, a wider implementation of SPEC-CT should be considered. So I'm done with my first presentation, and you can ask.
So you would like to get questions after the second presentation? Or no?
It's up to you, actually. Both presentations. Okay.
Okay, thank you very much. Interesting presentation. I have a question. If you clinically suspect pulmonary embolism, which will be first method of choice for you? Is scintigraphy or something?
Well, patients are referred for scintigraphy.
And
yes.
your opinion about computer tomography? If patient go to emergency department, you suggest to perform scintigraphy like fast choice or?
I would say yes. This is what guidelines recommend. And if the patient is suspected, I mean, computed tomography in this case, as we evaluated, gives additional value, but I'm not sure whether it's the primary method to use.
Okay, but if patient go to emergency department, not in Kaunas clinics, we are nuclear medicine department, but for example in Raseiniai or another city hospital which no have nuclear medicine equipment.
So of course they will implement then computed tomography.
Yeah, okay.
I just want to ask about the price of these two methods. Is it differs or?
Oh, I really don't know.
Okay.
But I think that SPEC-CT would cost more.
Thanks.
Do we have nuclear medicine available 24/7? No? Why not? I have a question about your contribution. So you did everything all by yourself?
Yes.
And what do you think? Which value is more important? Positive predictive value or negative predictive value?
I would say positive predictive value.
Okay, so you can move on.
Yeah, so my second presentation, as I mentioned before, the results are from the same patient population, and since we observed that SPEC-CT has better diagnostic efficacy compared to scintigraphy, we have also aimed to assess the incidence of the findings that are not related to the pulmonary embolism, but which occurs in those patients that we investigate. The thing here is, pulmonary embolism leads to ventilation and perfusion mismatch. But there are non-thrombotic lung diseases that can also create those mismatches. And for example, when we perform like scintigraphy, we can see that there is perfusion defect. But what's the origin of this perfusion defect? And SPEC-CT has computed tomography, which gives us the anatomical view. We can identify the structures and the pathology within those structures. And this is why we can, we aim to assess what are those changes. And some of those lung diseases can mimic perfusion defects observed in pulmonary embolism. This is why it's very important to determine what's the origin of ventilation perfusion mismatch. Otherwise, we can prescribe inadequate treatment and, for example, prescribe a treatment for pulmonary embolism which is not even present. SPECT-CT allows us to evaluate physiological and anatomical components simultaneously, and this is why other authors reported that it can assess the origin of the perfusion defects. So we aim to assess the incidence and the type of the perfusion defects that are not related to pulmonary embolism in the patients with suspected pulmonary embolism. So the methods were the same as I mentioned before, 61 patients with suspected pulmonary embolism, and we had the data from SPECT-CT. So as I said, pulmonary embolism was observed in 26 of 61 patients, whereas incidence ratio of the findings non-related to pulmonary embolism overall was 29.5. But here's important to emphasize that individually those findings didn't show very high prevalence, and the most prevalent finding was lung parenchyma consolidation, which was detected in 11.5% of patients. Other non-pulmonary embolism-related findings were lung foci, high diaphragm arcus, and pleural effusion, and individually those pathologies showed the same incidence ratio of 4.9%. Less common pathological findings were atelectasis and ground glass appearance. They individually accounted for 3.3%, and emphysematous bullae were found only in 1.6% of patients. And none of these findings were related to pulmonary embolism. So structural changes that resemble defects caused by pulmonary embolism can be assessed by SPECT-CT imaging. Findings that are not related to pulmonary embolism occurs in almost 1/3 of patients with suspected pulmonary embolism, but the incidence ratio of findings individually is not high. And the consolidation of parenchyma was the most common and occurred in approximately 1 of 10 patients with suspected pulmonary embolism. And because we observed that SPECT-CT allows us to identify whether other pathologies that might mimic those perfusion defects observed in pulmonary embolism, we concluded that that SPECT-CT reduces false positive findings that occurs in lung scintigraphy imaging, and this is what I said in my previous presentation, that lung scintigraphy had a higher incidence ratio of false positive and false negative results. So that's it. Now you can ask.
All right, thank you very much. Regarding incidence ratio of findings non-related to pulmonary embolism, it was 30%.
Yeah.
You think it's high, low, it's normal when you compare with other centers?
Actually, I didn't compare to other centers, yeah, so I cannot say if the ratio is the same or not. Well, 1 of 3 patients have, but I think that it's quite high ratio to implement SPECT-CT. Because if we won't implement SPECT-CT, we can miss that 1 of 3 patients, because planar scintigraphy can underdiagnose.
So you would like to put more patients on radiation?
Computed tomography is performed on low dose, and it's quite safe.
Okay. What is the incidence of artifacts in SPECT-CT?
There are artifacts, but the incidence ratio is not very high. I cannot say what specifically is the ratio, but it's not very high. But there are, of course, there are.
All right. I also would like to give a recommendation, and also for the another presenters, try to use the graphs from the statistical packages. It's much more informative when you're just putting a text. Okay, in the future. Other questions?
Thank you for presentation. Maybe it's more related to your previous presentation. I wonder how often is applied SPECT-CT comparing to planar scenography in other countries? Do you have any data or?
Well, there are many studies that report the value of SPECT-CT, so I think that the implementation increases because pulmonary embolism carries a high risk for that, and investigators do studies to find what's the added value, and they implement because there are many studies reporting the value.
Thank you, Vaiva, for your presentations. Thank you, the jury, for your questions and insights. And for the last presentation, I would like to ask Augustina Gilienė to present a topic about Crohn's disease activity in DICE reflecting treatment response.
Hello, everyone. Today, I am Augustina Gilienė. I'm a sixth-year medical student, and today I will present our research, which we conducted together with my scientific mentor, Vestina Strakšytė, Crohn's disease activity indices reflecting treatment response. Crohn's disease is a lifelong and progressive inflammatory disorder of the gastrointestinal tract, which manifests with remitting and relapsing symptoms. The symptoms may be various and non-specific, such as abdominal pain, fever, fatigue, and diarrhea, which sometimes can be with blood. And it typically occurs in young adults between second to third decade of life. And Crohn's disease may affect all gastrointestinal tract from the oral cavity to the anus. And there are several factors that are considered responsible for development of Crohn's disease, including environmental factors, genetic features, and specificity of intestinal microbiota. And although there's no single diagnostic test for inflammatory bowel disease, the magnetic resonance enterocolonography and abdominal ultrasonography are important modalities in assessment and management of Crohn's disease. It is not possible to permanently cure Crohn's disease. Therefore, the main goals are to reduce inflammation, achieve remission, and improve patients' quality of life. Usually, the treatment is started with drugs, but later, almost half of patients require surgical therapy. However, sometimes the disease may become resistant to many used medication. So our aim today is to evaluate Crohn's disease patients' responsiveness to treatment using different disease activity indices. We conducted a prospective study of 37 Crohn's disease patients' medical data. All of the patients had their treatment and then after 6 months underwent magnetic resonance enterocolonography, endoscopy, and had their blood test done. The patients were divided into 2 groups according to Crohn's disease activity index, where more points just means the higher activity of the disease. So the non-responders group, 21 patients, consisted of the patients whose activity index scores increased or decreased by less than 70 points, which is just considered as a threshold of clinical response. And the responders group, 16 patients, either achieved remission or their activity index score decreased by 70 or more points. Our evaluated magnetic resonance enterocolonography indices included magnetic resonance index of activity global, modified magnetic resonance index of activity global, and Clermont global index. The inflammation indicators in the blood test were C-reactive protein and white blood cell count, and other indices included Crohn's disease endoscopic index of severity, Le Mans index, and inflammatory bowel disease questionnaire, which basically is a subjective questionnaire which reflects patients' quality of life. So in the non-responder group, the 21 patients, you can see that no significant changes in any indices were observed. The activity index even rised a little bit, and the magnetic resonance indices decreased, but not significantly at all. The inflammation, according to blood test, was not reduced significantly. The endoscopic index of severity also reduced insignificantly. Le Mans index, of course, and according to inflammatory bowel disease questionnaire, patients' quality of life improved only minimally. And in responders group, you can see that there's a lot of differences. The activity index decreased by more than 100 points, which is a statistically significant result. The magnetic resonance indices also decreased significantly. The inflammation was reduced according to blood test. Endoscopic index of severity also decreased significantly, and the only one index that did not change significantly was Le Mans index. And according to inflammatory bowel disease questionnaire, patients' quality of life did improve. So this leads me to my conclusion, that is that only the responders group achieved a significant increase in life quality and decreased magnetic resonance enterocolonography, endoscopic, and serum Crohn's disease activity indices after the therapy. And in both groups, as you could see, minimal changes in Le Mans index scores were observed. So that's all from me. Do you have any questions?
Thank you very much for the presentation. Now we move to the questions.
Thank you for nice presentation. I have a short question. Where do you see, after collecting this data, where do you see the added value of the MRI imaging in clinical practice? As we can see that obviously the questionnaire, the simplest of it, gives us already the results for responders. What do you think, the MRI should be done or not for these patients and for the clinical practice?
In daily practice, you mean?
Yeah.
I don't think it's possible to do such big index as Maria G, as you can see, because it is a big assessment actually, and it consists of assessment of 6 defined anatomic regions, and then there goes that big equation in which you have to put all the values you could see, and I think it's very time consuming, and it is not always necessary to do such big indices in order to just conclude that it is Crohn's disease or it is not Crohn's disease. I think that it's not always necessary for Maria G global.
Thank you.
You can even do CRP if it's going down, so you have responder. Yeah. What I like that the study was prospective, so because the previous were more retrospective. Any other questions?
Thank you for presentation. I would like to ask what percentage of population have this disease in Lithuania and the world?
I'm not quite sure about the numbers, but inflammatory bowel disease overall, including colitis, ulcerative colitis, it is quite large part of population has this disease, I think.
And what is your contribution to this study?
Mostly, I did the theoretical part of the study.
Thank you.
I would like to thank the jury for their work, presenters for their delightful presentations, and now let's take a 7 minutes break while all the scores are counted. Right after the break, we will announce the session's winner and congratulate them. So welcome back. I would once again would like to thank the jury for their work today, for making this session lively. Thus, after counting all of the jury points, I'm delighted to announce that the winner of the session is Augustina Gilienė and Vesina Straškytė, who won the first place in our conference. I would like to thank all of the participants for attending the 6th International Health Sciences Conference. Hopefully it was interesting, and now I invite you to join the rest of the conference and come to listen for the today's keynote speaker, Associate Professor Dr. Vincas Urbonas. But before that, I would like to ask Vaidas Pelinauskas to congratulate Augustina.
I would like to use this opportunity and first to thank organizers for inviting me and for organizing this conference. I think these conferences are really important, and both for sharing your knowledge and your achievements in the field, but also for getting together and knowing each other and for all these communications. So on behalf of the Lithuanian Young Academy, I also would like to congratulate you for this achievement. I hope that at least some of you will continue the academic path and the young researchers careers, and maybe we'll see each other in Young Academy or in Lithuanian Science Academy. Thank you.
So thank you all. If you want, you can also take a photo at our photo stand. And also, I would like to give the gift back to the jury members.
the 6th International Health Sciences Conference Neurosciences session. My name is Tautvydas Puslys, and I'll be leading this session today. First of all, on the behalf of the Student Scientific Society of Lithuanian University of Health Science, Lithuanian University of Health Sciences, I would like to thank our patrons, Fresenius Kabi, Roche, Medita, Origmed, and others for helping us to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedical fields. We hope that this conference will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, odontology, pharmacy, and public health with young scientists all over the world. Additionally, I would like to express gratitude for all of the reviewers and today's jury, Brigita Glebauskienė, Professor Vesta Steiblienė, and Professor Renata Balnytė. We kindly ask jury members to remain at the session until the points are counted and the winners is announced. And before starting the session, I would like to remind you some rules that today we will hear 8 presentations. All of the presentations will be evaluated by the jury. Based on the average scores given by the jury, we will choose one winner from this session, and the winner will get great sponsored awards, gifts from Bioderma, Sapiens, Chrysostomos Bookstore, Origmed, Gintarinė Vaistinė, Filman, and Medita. And winners will receive their gift after the session. Moreover, presentation should last no more than 7 minutes, and after that, 3 minutes will be dedicated for the questions from the jury members and listeners. Please note that if your presentation will take more than 7 minutes, you will be asked to go to the final slide and finish your presentation. I ask jury to fit in the given time frame as well. And each presenter will receive a certificate that will be sent to their emails after the conference. So maybe do you have any questions before we start the session? So best of luck to all the presenting authors. And now I would like to invite the first presenter, Urte Andriušaitytė, to give us the first presentation, measuring alexithymia in healthcare professionals, which factors are related to it.
Hello, my name is Urte, and today I would like to share with you our pilot measuring alexithymia in healthcare professionals, which factors are related to it. So first of all, alexithymia refers to a psychological construct characterizing individuals with a deficit in emotional expression and processing, which leads to a difficulty in discriminating emotions from bodily sensations and discriminating cognition from emotion. And what is very important, that alexithymia is frequently associated with major depression and anxiety disorders. And many researchers indicate that people with alexithymia are more likely to develop the feeling of tension when staying in a high-pressure working environment. And especially that was the point when we started to think that this might be very significant talking about medical community. And there are several studies showing connection between alexithymia and burnout syndrome. And as many of us know, approximately 1/3 of physicians have experienced burnout throughout their careers. And the mechanisms through which alexithymia might increase the likelihood to develop burnout include various aspects, and most of them, of course, are related to the management of relationships in the stressful working environment, and of course, related to occupational stress at work. And shortly, what is already known in population is that the prevalence of alexithymia is reported to range from 10 to 13%, which is kind of big number. And also some population studies have found, for example, females to be less alexithymic than males. And bearing that in mind, we decided to analyze the prevalence of alexithymia in medical community of Lithuania. And also we were interested to evaluate the differences depending on sex, age, branch of medicine, and the experience stress level. We invited medical personnel to participate in the study using social networks. And we gathered the data by self-rating questionnaires. And shortly, the questionnaires consisted of two parts. The first part was the Toronto alexithymia scale to evaluate alexithymia, and other questions were related to personal information such as branch of medicine, age, and subjectively experienced stress level. And altogether, 254 participants were selected for the study. And how the Toronto alexithymia scale worked. So the greater than 60 points were meaning high alexithymia, and less than 52 points were meaning lack of alexithymia. So the mean of TAS 20 alexithymia score was 45.2. And what's very striking that almost a third of participants had alexithymia or a tendency for alexithymia, which was higher mean if compared to general population. And later on, we compared alexithymia scores by different factors. For example, by gender. However, no significant difference were found. Also, we compared alexithymia scores by age, and we categorized participants in two groups. One group was less than 39 years old, another group was more or equal than 40 years old. And interestingly for us, younger doctors had a little bit higher number of alexithymia scores. However, it was not enough to make it statistically significant. Very similar situation was applied for branch of medicine. We selected like two branches of medicine, surgical and therapeutic one. And where I would like to stop is the experience stress level. And here we have more interesting results. So firstly, average stress level was way higher than average. It was 6.8. And when we evaluated stress level by alexithymia category, the significant difference was found. And it correlates with other researchers' data that non-alexithymic people had less, they evaluate their stress level as not that significant if compared to alexithymic people. And our data agree to the fact that alexithymic people tend to experience stress more prominently if compared to non-alexithymic population. And the main points that I would like to emphasize as conclusions. So the results of this pilot study showed that 28.4% of medicine practicing individuals have alexithymia or a tendency for alexithymia. And importantly, tendency to alexithymia might be related to experience stress level. And I think it's even more important talking about this in COVID times. So that were our main conclusions, and thank you for your attention.
Thank you very much for your interesting presentation and nice research. I have one question. What do you think? Why more alexithymic subjects decided to be medical professionals? Because you show that in medical professionals it's higher than in general population, this alexithymic. Just what's your thoughts?
Thank you for a very interesting question. Actually, as I read, alexithymia might be like primary and secondary. And I think when we are talking about medicine practicing individuals, it's very important that alexithymia might be caused by that constant stress and occupational pressure and occupational stress. So actually, I was thinking about that before. It would be very interesting to analyze, was this alexithymia like from the very beginning of the person's life, or was it related more to the stress at work and maybe long work hours? So I think it's due to that more, due to stress at work, maybe.
Thank you for your answer. I think it will be the next step in your research, yes?
Yes. Thank you very much.
Thank you.
So thank you, Jurta, for your presentation, questions and answers. And the next presenter is Violetta Vintortaite with the topic MIR200A3P expression in the serum of patients with Parkinson's disease.
So hello, today I'm going to present a study about microRNA 200A3P expression in the serum of patients with Parkinson's disease. So Parkinson's disease is a neurodegenerative disorder that results in tremor in bradykinesia due to the death of dopaminergic neurons. And neuronal death can occur due to multiple pathological events, such as alpha-synuclein aggregation and accumulation in neurons, oxidative stress, dysregulated cell survival mechanisms, neurotoxicity, neuroinflammation, and so on. And all of those mechanisms are affected by multiple factors, and one of those factors could be microRNA molecules. MicroRNA interference has been extensively studied due to its effects in many biological processes, including manifestation of neurodegenerative diseases. MicroRNA molecules are formed in various body cells. They can be packed into extracellular vesicles, then infiltrate the extracellular space and travel through biological fluids, providing long-lasting effects of disease-related genes. And in the present slide, you can see some of the genes that are regulated by microRNA 200A3P, and the effect it has according to the latest studies. So microRNA 200A3P was selected as a potential biomarker for further investigation, and the need for innovative biomarker for such disease is because it progresses for several years before a clinical diagnosis is made. The treatment isn't curative, and it also can vary considerably from patient to patient. Also, extracellular vesicle-associated microRNAs are expecting to help differentiate diseases, their stages, and their progression. So the aim of the study was to determine extracellular vesicle-associated microRNA 200A3P expression in the serum of patients with Parkinson's disease. MicroRNA expression was evaluated by patient's age, sex, the onset of the disease, its duration, severity of symptoms, and selected method of treatment for 88 individuals with Parkinson's disease. 36 control group patients received medicational treatment, 39 underwent deep brain stimulation, and 13 received gamma knife surgery. So extracellular vesicle-associated microRNAs were isolated from collected samples of blood serum, then transcribed into cDNA, and their expression was evaluated by real-time PCR. Statistical analysis was performed using students' t-test, ANOVA criteria, Pearson's correlation coefficient, and GraphPad Prism 8 program. And the results revealed that patients who were assigned for surgical Parkinson's disease treatment, so either deep brain stimulation or gamma knife surgery, showed quantitatively higher levels of microRNA 200A3P in their blood serum compared to the control group. Also, it was noticed that control group patients mainly experienced no to mild Parkinson's disease symptoms, patients colored in green, whereas surgical treatment groups mostly faced moderate to severe intensity of tremor and bradykinesia, patients colored in red. So, patient data were pooled into groups by severity of their symptoms to address whether the severity of Parkinson's disease was associated with increased levels of microRNA 200A3P. And a NOVA test confirmed that as symptoms of bradykinesia become more intense, microRNA 200A3P levels increase gradually. Similar results were observed as symptoms of tremor intensify, but these results were not statistically significant. MicroRNA 200A3P was not affected post-surgical treatment when using paired Students t-test. MicroRNA molecule did not seem to have a significant tendency to increase or decrease after gamma knife surgery, neither deep brain stimulation. Also, no significantly relevant microRNA 200A3P expression was observed between genders. And lastly, microRNA 200A3P correlation between disease-related patient data were evaluated, and it seemed that microRNA correlation with patient's age and the onset of the disease were negligible. However, low correlation was observed between microRNA 200A3P molecule and the duration of the disease. And in conclusion, primary data suggest that patients with elevated extracellular vesicle-associated microRNA 200A3P expression levels experience stronger Parkinson's disease-related symptoms and then require surgical treatment. MicroRNA 200A is a non-gender specific biomarker, and its levels were not affected post-surgical treatment. Also, low correlation between microRNA 200A3P expression levels and Parkinson's disease were observed. However, more detailed studies are needed to support obtained results, which could be useful in clinical practice. And that's it. Thank you for your attention.
Thank you for very, very interesting your work. And I would like to ask, maybe you know or have data, what is prevalence of this gene in general population, or you don't analyze? Just patients.
Well, we didn't analyze this microRNA molecule in general population because, well, we aimed to find an innovative biomarker for Parkinson's disease.
Mm-hmm.
Yes.
What's interesting will be how in general population. Thank you. And what is your contribution in this job? What you do?
I isolated first of all, I selected which microRNA molecule to investigate. Then I isolated those microRNA molecules, did all the lab research, then did all statistical data. So.
Thank you. Great job. Thank you. Good luck.
Thank you.
So once again, thank you, Violeta, for your interesting research. And the next presentation is the effect of blood pressure on optical coherence tomography parameters by Kristupas Uslavičius.
So, hello, my name is Christopher. I'm fourth year medical student, and today I would like to represent for you the effect of blood pressure on optical coherence tomography parameters. So, based on the records based on Eurocast data, in 2019, more than 2 out of 10 people in Europe had high blood pressure, and it's associated with cardiovascular, cerebrovascular, and eye diseases. So, over last decade, great efforts have been made in order to find some kind of correlation between high blood pressure and retinal nerve fiber layer, or RNFL, thickness, and ganglion cell inner plexiform layer, GCIPL thickness. And our study aim was to evaluate the effect of blood pressure on optical coherence tomography parameters in women with healthy retina. So, our study was the base of pilot perspective. It was a pilot perspective study that included women that were more than 50 years old, and we measured such things as age, primary arterial hypertension, analysis of drugs, monitoring blood pressure, and by ourselves, what we did is best corrected visual acuity and eye pressure. So, devices that we used were biomicroscopy, ophthalmoscopy, and OCT. And with OCT, we used 2 main functions: is RNFL, retinal nerve fiber layer measuring, and macular scans. And those macular scans have also 2 functions: is GCIPL, or ganglion cell inner plexiform layer thickness, and inner limiting membrane retinal pigment epithelium thickness. So our main method was, we used, of course, SPSS, t-test, and Pearson correlation coefficient. So our results. Our study included 50 women, or 100 eyes, and the median age was 64 years. And almost half of the patients had primary arterial hypertension, and they all were treated. Yeah, so... And it's important to mention there were no statistically significant difference in age between subjects with primary arterial hypertension and without diagnosis of primary arterial hypertension. So our results: the mean blood pressure was systolic 129.34 and diastolic 81.68, and they were all normal. And the mean BCVA was 0.9. So the mean eye pressure was 17.57 millimeters of mercury, which is also normal, and a strong negative correlation was found between age and BCVA. So, our results. We found a negative correlation with age and GCIPL thickness, medium correlation, negative correlation with systolic blood pressure and RNFL, or retinal nerve fiber layer, and very same kind of correlation between systolic blood pressure and ganglion cell inner plexiform layer. And overall strong multicollinarity between age, systolic blood pressure, and GCIPL thickness was observed. And also it is important to mention that we found very weak or not significant correlation between diastolic blood pressure and OCT scans, so that's why we not included that. Also, our results: the group of primary arterial hypertension had statistically significantly higher blood pressure and lower average RNFL and thickness and GCIPL thickness in comparison with subjects that did not have primary arterial hypertension. And conclusions: that high systolic blood pressure might be related to the reduction of retinal GCIPL, or just ganglion cell inner plexiform layer, and retinal nerve fiber layer thickness. And subjects with primary arterial hypertension had higher blood pressure and lower average retinal nerve fiber layer and ganglion cell inner plexiform layer thickness. So that's pretty much it. Thanks.
Thank you for a nice presentation. What was your contribution in this work?
Yeah, so I measured by myself all the OCT scans, did by myself. did all the measuring and all the BCVA. Also, I did all the stuff with the calculations, yeah, did by myself, yeah. Found the correlations and pretty much it, yeah.
Okay, and one more question. What were your exclusion criteria?
Exclusion?
You've told that it had to be patients with healthy retina, but did you pay attention to optic nerve and refractive errors?
Yeah.
So exclusion criteria.
Yeah, so good question. We excluded those that had any kind of disease with their eyes, any kind of disease, that had glaucoma, that were smoking, just not living a healthy lifestyle. So just 50 women that were just fine and living a good life.
Okay, thank you.
Thank you. I would like to ask why you analyzed just women.
Women, because there were more women coming to hospitals than men. And when you ask a man for, can we do some kind of OCT scans and just for free and all that, and we can diagnose any kind of disease for you, they say no, that's it. So this is why there are much more women, and we excluded men also.
Okay, thank you.
Thank you.
So thank you for your interesting work, and let's move on the next presentation, MRI Findings Association with Multiple Sclerosis Disease Course and Disability by Ieva Viena-Žindytė.
So, hello everyone. It's my pleasure to be here. My name is Ieva Viena-Žindytė, and today I'm going to present our research, Magnetic Resonance Imaging Findings Association with Multiple Sclerosis Disease Course and Disability. Magnetic resonance imaging is an important element in the diagnostic process of multiple sclerosis, also known as McDonald criteria, an invaluable tool for multiple sclerosis diagnostics. Furthermore, it can also work as a biological marker of the severity and progression of this disease. In our research, we are investigating the association mentioned above and sharing findings from our local multiple sclerosis center. The aim of the study was to identify and investigate MRI findings at the moment of multiple sclerosis diagnosis and its association with disease course and disability. We included 120 patients with multiple sclerosis diagnosis who were treated at a Department of Neurology of Hospital of Lithuanian University of Health Sciences Kauno Klinikos. The MRI data and information about disease course were collected from medical documentation, which was found in outpatient department. Disability assessment was made according to expanded disability status scale score on diagnosis and latest visit to the clinic. The multiple sclerosis severity score was calculated using a conversion table based on expanded disability status scale score and duration of disease in years. Statistical analysis was performed using IBM SPSS and using Mann-Whitney U-test and Chi-square. The study involved 44 male and 76 female patients with an age median of 44 years. Expanded disability status scale score median on diagnosis was 4, from 1 to 7. The distribution of disease courses are shown below, and as you see, we had mostly relapsing remitting multiple sclerosis and secondary progressive multiple sclerosis patients. Almost all our patients had periventricular lesions, and the other lesion sites are shown in this chart, where dark blue represents relapsing remitting multiple sclerosis, gray primarily progressive multiple sclerosis, and a brighter blue secondary progressive multiple sclerosis. Periventricular lesions were most frequent in relapsing remitting patient group, as well as corpus callosum lesions. Lesions in brainstem were mostly found in primarily progressive multiple sclerosis patients, cerebellum and subcortical lesions in secondary progressive multiple sclerosis patients. Lesions in the cervical and other parts of the spinal cord showed a tendency to be found in primary progressive multiple sclerosis type patients. Unfortunately, these differences were only seen in our research descriptive statistics, while statistically significant differences between localization and disease course are absent. MRI changes on diagnosis and also a number of different localizations had no statistically significant differences between disease courses. Expanded Disability Status Scale score on diagnosis had no statistically significant differences between different localizations of MRI findings. Multiple sclerosis severity score median for all patients was 7.11. And what is important, that only patients with lesions in brainstem on diagnosis MRI, multiple sclerosis severity score median was statistically significantly higher compared to those who had not. It was 7.60 versus 6.48. At a moment of multiple sclerosis diagnosis, MRI lesions found in brainstem, cerebellum, and spinal cord could be associated with more severe forms of multiple sclerosis. As you saw, it was mostly found in primarily progressive and secondary progressive multiple sclerosis patients. Lesions found in brainstem can also predict the possibility of a higher disability progression. Multiple sclerosis severity score median for them was 7.60. And the lack of statistically significant correlations might be associated with a limited sample of lesions in different localizations. Thank you for your attention, and I will gladly answer your questions.
Thank you for your work and your presentation. And I would like to ask you, when you analyze the literature of other researchers, if this corresponds your findings with other findings?
Yeah, it's kind of correlated with other research data, but our data was not that statistically significant, so I just can't make a conclusion for it.
But you have a hypothesis before this work. What was your hypothesis?
The hypothesis was that the first magnetic resonance imaging findings correlates with the disease course and disability, that we can predict the severity and progression in the future, because it is important to, as soon as possible, treat patients with disease-modifying therapies, and these are just different for each course. So we have to know it as soon as possible.
Thank you.
So once again, thank you, Ieva, for your delightful presentation. And now I would like to invite Ugnė Masiulionytė to give us the presentation IL-10 gene RS180087I single nucleotide polymorphism in patients with multiple sclerosis.
So, hello everybody, my name is Ugnė Masiulionytė, and today I will present my scientific work on interleukin-10 gene RS18000871 single nucleotide polymorphism in patients with multiple sclerosis. So multiple sclerosis is a chronic autoimmune disease of the central nervous system that causes demyelinization and neurodegeneration. It is the most common disease in young people, affecting approximately 2.3 million people worldwide. The etiology of the disease is unclear, but genetic and environmental factors, such as alterations in the human leukocyte antigen DRB1 locus, decreased vitamin D levels, UV radiation, Epstein-Barr virus infection, smoking, and obesity are known to contribute to the risk. Recently, more and more attention is paid to the research for new genetic markers' importance for the development and progression of multiple sclerosis. One of the genetic factors that may be associated with the development of MS in the clinical course could be the interleukin gene 10 gene polymorphisms. So interleukins play an important role in the immune system, and their pathological changes can lead to autoimmune diseases such as multiple sclerosis. Interleukin 10 is an anti-inflammatory cytokine and an immune regulator, leading to the inhibition of Th1 and the production of pro-inflammatory cytokines such as tumor necrosis factor alpha and interferon gamma. Interleukin 10 is located on the chromosome 1, and the promoter of this gene has 3 single nucleotide polymorphisms. And this interleukin 10, RS871, has shown to be associated with low or high production of this interleukin. There is information that interleukin 10 has correlation with disease remission in MS, and expansion in interleukin 10 producing cells were found during remission course. And low interleukin 10 production are observed prior to disease relapse in chronic remitting MS. So our aim was to determine the relationship between interleukin 10, RS871 genotypes and alleles in patients with multiple sclerosis. So the study was conducted in Neuroscience Institute in the ophthalmology laboratory, and the study enrolled 75 patients with MS and 197 healthy controls. So samples of DNA from peripheral blood leukocytes were purified by salting out in commercial kit. The genotype test was carried out by using the real-time chain reaction method, and the statistic analysis was used by the SPSS statistics software. The categorical data, so the gender, genotypes, and the allele distributions were presented as absolute numbers and using the chi-square test. The impact of gene polymorphism on MS was evaluated using binomial logistic regression results and presented as odd ratios with 95% confidence interval. And the logistic regression analysis results was expressed like genetic models. So there was common, dominant, recessive, and adaptive model was used to evaluate the impact of each minor allele in MS. And the best genetic model selection was based on the ICIC information criteria. So the results were that our data demonstrated no statistical significance difference in interleukin 10 gene polymorphism between patients with MS and healthy controls. Also, the analysis revealed that interleukin 10, RS871, AA, AG, and GG genotypes did not statistically differ between MS and males and females group. And when analyzed by age, the less than 30 and under 30 AA, AG, GG prevalence in both the groups had no statistical differences. So the conclusion is that although our scientific research had no statistical differences, but study with smaller group are more likely to lack statistical power influenced by overall results. As MS is multifactional and there could be gene-environmental interactions, as I mentioned before, that could be also influence our results. So further case control studies with a larger number of subjects may provide more significant results. So that's why we're gonna add 50 more new samples to this study. And because it is important for the scientific world to understand more about multiple sclerosis. So thank you for listening. And I would like to thank all the ophthalmology laboratory for helping me with the study.
Thank you for your presentation. And I would like to hear what were you exactly doing in this work?
So I did all the genotyping on the patients with MS and the healthy controls. So every week, maybe 2 or 3 times a day, I went to the laboratory and did all the statistics with help.
And how do you think what maybe inclusion or exclusion criteria you should change to get more precisely results? Statistically significant.
So thank you for the question. I think maybe we could divide the patients which have MS into groups with the courses of the remitting course and the relapse course, and just see which course they were during that phase when we extracted the blood from them. Thank you.
Thank you. I would like to ask one question. Thank you for interesting work. About MS patient. All MS patients have diagnosis according to McDonald's criteria? You don't analyze here disease course, yes?
No, we didn't analyze the disease course, but we did know that the patients had MS.
MS, just MS?
Yes, but we don't know what course they were. Did they had some environmental factors? We just knew the patients, if it's a female or a male, and we know the age.
Okay, thank you.
So maybe in the future we could categorize.
Will be interesting, thank you.
Thank you.
Thank you, Ugne, for your great work. So the next presentation is a genetic risk score to aid differentiation of ON at presentation by Pavel Loginovich.
Hold on. Right, okay, hello, my name is Pavel Loginovich. It's a huge pleasure to be presenting our work today. So our work is titled A Genetic Risk Score to Aid Differentiation of Optic Neuritis at Presentation. So just a few words about optic neuritis. What is it? Inflammation of the optic nerve, and it can be associated with multiple sclerosis. It often is a first presentation of multiple sclerosis, MS, and if it is associated with MS, we would call that MS-ON. Now, if it is associated with MS, we would not treat that with urgent immunosuppression. It's of little benefit. If optic neuritis is not associated with MS, often it does require prompt treatment with IV steroids, and the aim of that treatment is avert permanent blindness. Now, the challenge at the moment is that it's very hard to know what kind of optic neuritis you have in front of you at presentation. And our simple question was, can we use genes, can we use genetics to help understand what subtype of optic neuritis we're dealing with? So what we did, we looked at the UK Biobank data. So our population came from a large collection of genotypes and phenotypes done by somebody else. And it was 500,000 people. It had retrospective and prospective data available from hospital records. And we defined our cases based on ICD-9, ICD-10, and family doctors' codes as well, so on as many codes as we could. Next, we constructed a genetic risk score. So what that is, it's basically you look at 308 single nucleotide polymorphisms from all the genome, and you score them. So similarly to what has been presented, we looked at them, and we summed them up for the non-HLA. For the HLA component of the GRS, we looked at 8 HLA alleles and 2 single nucleotide polymorphisms from that region. A good example of such an allele we looked at was DRB1501. And essentially, just to reiterate, genetic risk score, you look at many, many SNPs, and you sum them up, and it's a number that shows a polygenic risk score. Okay, so in terms of results, we had a bit more than 2,000 cases of MS and 700 cases of optic neuritis. Now, 266 out of 687, so approximately 40% of optic neuritis cases were associated with MS. And we'll need this later, but we had 529 people who had optic neuritis and did not have MS before they were diagnosed with ON. Yeah, so let's take a look at our genetic risk score and how that looks. So on the x-axis, on this figure here, we have genetic risk score, and here in this end, we would have low genetic risk score, so virtually non-risk alleles, and there would be high genetic risk score. So immediately what we can see is that the blue and the purple lines overlap, meaning that people with MS-ON have identical genetic risk score to people with MS only. And people with optic neuritis only had a lower genetic risk score, and it was highly statistically significant. So people in red had lower genetic risk score. That's good, but what can we do with that? Can we try and predict MS in people with optic neuritis? So here we use the population of optic neuritis without baseline MS. You can see the characteristics here. And what we did, we fitted a Cox proportional hazard model, which is a MS-free survival model. And we used MSGRS, we used sex, and we used age diagnosis. And importantly, MSGRS was significant in the model. So you can see it's there at the bottom, and it shows hazard ratios per unit of increase in genetic risk score. So what we did then was stratified by predicted risk. So we cut all those people into quartiles of predicted risk, and we plotted MS-free survival in years here on the x-axis, and on y-axis we had MS-free survival probability. So essentially what we're showing here is that our model, which uses genetic risk score, stratifies people who present with optic neuritis according to the risk of future MS. And it's important to know that each quartile has a decreasingly lower risk of MS. And when we compare this model, full model, with genetics to a null model, so covariates only, this model performed much, much better. So to conclude, we created a MSGRS which was discriminative of multiple sclerosis. That's good. Our MSGRS improved prediction of future MS in undifferentiated optic neuritis, so in people with ON without prior MS. And basically what we show here is pilot work that MS using genetics can help stratify people according to MS risk and could potentially inform investigations and treatment in high-stakes environment. So of course this is a pilot work and it needs to be validated in other data sets. But yeah, thank you very much for listening. And last but not least, I'd like to thank all the people I had a pleasure to work with. Thank you. Happy to take any questions.
Thank you for very nice presentation and very interesting work, and thank you for your team, of course. And we would like to ask you, what is your contribution in this work?
So I did most of the statistical analysis. I participated in creating the question, but essentially it was just analyzing the data. So yeah.
Thank you. Very interesting. I would like to ask, you didn't see some clinical points of this patient because very big group, MRI findings or oligoclonical bands about this patient?
Yeah, so...
because this is important things when we talk about future, about predictive factors of MS.
Yeah, we really wanted to use MRI, but the problem with this data set is that they could have been diagnosed years before they got an MRI. So MRI is time sensitive, so we couldn't use that because, yeah, it was time sensitive. But we used some other covariates such as smoking, ethnicity also, so something that doesn't change throughout the life.
Okay, thank you. And what do you mean optic neuritis associated with MS? Optic neuritis, and after you make diagnosis MS, or I don't understand this.
Oh, right. So it could be both ways. You could have MS and then have optic neuritis.
Or you
after.
have optic neuritis with
And
lesion in MRI and then make
then you develop MS.
Okay.
Yeah.
Thank you.
Okay, thank you for your presentation. And I would like to ask if optic neuritis is not caused by MS, so it can be caused by lots of other reasons, bacteria, viruses, whatever, idiopathic. So maybe why you didn't analyze it thinking about other causes, because it can cause lots of immunological changes.
Yeah. We started doing that actually. So you can create a genetic risk score for ankylosing spondylitis, and you could, you know, have 2 scores and just have basically look at many scores, and you can look at other causes as well. But this is just sort of, you know, sub-analysis.
It's for the future.
Yeah.
Okay, thank you.
Thank you.
So thank you one more time, Pavel, for your presentation. And the next presenter is Karina Statkevičienė with the topic Changes in the Prevalence of Glaucoma and Glaucoma Suspects in Lithuania during 2001-2020.
And I'm a medical student in Lithuania University of Health Sciences. And today I'm going to talk about the changes in the prevalence of glaucoma and glaucoma suspects in Lithuania during 2001 and 2020. Glaucoma is an optic neuropathy which is caused by progressive death of retinal ganglion cells. It is characterized by cupping of the optic nerve and visual field loss. Glaucoma can be asymptomatic until a severe stage, and it is expected that almost 50 to 90% of patients remain undiagnosed worldwide. So according to the World Health Organization, glaucoma is the second leading cause of blindness globally. This disease is multifactorial, and the most common cause is increased intraocular pressure. Glaucoma can affect people of all ages, but it is more prevalent in people over 40 due to the rapid increase in aging population worldwide. And based on prevalence studies, it was estimated that in 2020 about 76 million people suffered from glaucoma, and in 2030 this number will reach approximately 111.8 million. So our study aim was to assess trends in the prevalence of glaucoma and glaucoma suspects in Lithuania during the last 2 decades. We performed retrospective data analysis, and data was obtained from the Institute of Hygiene, and data assessed using joint point regression analysis. So as you can see in this chart, in 2020, the overall prevalence of glaucoma and glaucoma suspects was 3,137 per 100,000 of the population. And based on international research forecasts, the estimate number of cases in Lithuania may actually be twice bigger. So during the last 2 decades, the average annual increase among adults was 6.6% per year, while among children was 3.2% per year. And the prevalence of glaucoma and glaucoma suspects was higher in women than in men. The morbidity from 30 years of age is growing rapidly, and from 1,254 to 11,621 per 100,000 population, and the highest increase of glaucoma and glaucoma suspects was observed in patients older than 80 years. And the conclusion, so the prevalence of glaucoma and glaucoma suspects over the past 20 years in Lithuania was increasing, and this could be due to the significant improvement in eye examination and diagnostic tools, and in addition, older people are more likely to develop glaucoma. That's all. Thank you for your attention.
Thank you for your presentation and data analysis. And you mentioned there is reasons for this increased cases is better examination, better medical care. Maybe you have another thoughts about the reasons for increasing glaucoma, not only evaluation.
Also, the main reason is our population aging.
Thank you.
Thank you for your presentation. I would like to ask, maybe you can recommend prophylaxis that glaucoma don't increase, or just age associate with how you think?
I think yes, due to that people go rapidly to ophthalmologist, and also there is a little bit misunderstanding with coding system. The cases are growing.
Thank you.
So thank you, Karina, for your presentation. And so let's move on the last presentation of this session, efficacy of artificial intelligence in detecting diabetic retinopathy from retinal fundus images, a systematic review by Gabrielius Dailidė.
Okay, good afternoon. My name is Gabrielius Dailidė, and I will present the work of mine and my colleagues, Saulius Lagunavičius and Associate Professor Vilma Jūratė Balčiūnienė, efficacy of artificial intelligence in detecting diabetic retinopathy from retinal fundus images, a systematic review. So first of all, diabetic retinopathy is a complication of diabetes mellitus, which damages the blood vessels of retina, and early diagnosis and treatment are important for proper management and reduced risk of vision loss, as diabetic retinopathy is the leading cause of preventable blindness in working age population globally. Artificial intelligence-based algorithms have been used to detect diabetic retinopathy, and in fact, in 2018, first such algorithm was even approved by FDA in the United States of America. UK National Institute of Clinical Excellence guidelines states that diabetic screening program should have at least 80% of sensitivity and 95% of specificity to be effective. And another commission of experts have declared that 50% of specificity is already cost effective in diabetic retinopathy detection. So the purpose of this review is to evaluate the scientific literature about the efficacy of artificial intelligence in detecting diabetic retinopathy from retinal fundus images. Systematic review was carried out following PRISMA guidelines. PubMed and ScienceDirect databases were used for the search of scientific literature. Keywords and combinations of possible synonyms used for search were selected using medical subject headings dictionary, and articles were selected according to inclusion and exclusion criteria developed using PICO method. So this table represents the inclusion and exclusion criteria of our review. So to be included in our review, publications had to be written in English and had open access to full text. Be published in the last 10 years. Researchers had to use artificial intelligence to detect diabetic retinopathy. Diagnosis had to be made solely based on retinal images captured by fundus photography with no access to other data like optical coherence tomography or patient anamnesis. Index tests had to be compared with ophthalmologist diagnosis, keeping that ophthalmologist diagnosis was the ground truth. And efficacy of method must be evaluated by sensitivity, specificity, and area under receiving operating characteristic curve, short for AUROC. And we excluded the literature reviews and case reports of this topic. As well, I would like to add to this table that we excluded studies that were trying to detect only specific stage of diabetic retinopathy. And I would like to mention as well that there were no restrictions for the studies depending on the age, gender, and ethnicity of the patients. So here are the Prisma flow diagram that represents the studies gathered from the databases. So as you can see, from initially gathered 2,322 studies, finally 15 studies from 14 different reports were included in our review. Researchers used different image sources for training and testing their artificial intelligence algorithms. So about half of the researchers used publicly available datasets that are written in the slide. Other group gathered their own images from the local hospitals. And the third group mixed the images gathered from locally from the hospitals and from the datasets available. Sample size in studies varied quite a lot, and the total sample size of a little more than 150,000 images were included in this review. So average sensitivity of artificial-based algorithm was 92.58%. Roy-Choudhury et al. Reached 100% sensitivity, and it was the highest amongst all, and Pei et al. In one of his studies included, reached 76.2%, which was the lowest amongst all. Average specificity was 87.22%. It was harder for the researchers to achieve high specificity than high sensitivity. And He et al. And Shah et al. Achieved the highest specificity of 98.5%, while Roy-Choudhury et al., which reached the highest sensitivity, reached the lowest specificity amongst all with 53.2%. And average AUROC was 0.937, with highest achieved by Li et al. And Shah et al. Reaching 0.991, and lowest of 0.843 achieved by Pei et al. In one of his studies. So our results show that artificial intelligence-based algorithms can accurately detect diabetic retinopathy in retinal fundus images, and these systems should be considered of use in clinical practice to save time and reduce costs. As I mentioned, the National Institute of Clinical Excellence guidelines requirements for the diabetic retinopathy screening. There are several studies that achieves that requirements, fulfills them, and integrating these algorithms into healthcare systems would benefit the patients and all the healthcare system. So these are my references, and I will be happy to answer your questions if you have any.
Thank you for your presentation. And how do you think when artificial intelligence could replace doctor?
There in the literature that we found, it states that it's not likely that artificial intelligence would fully replace doctors. In example for diabetic retinopathy detection, because both doctors and both artificial intelligence have their own strengths. and they add to each other. Because artificial intelligence will not get tired, it will always mark the same lesion if there is one, but as well doctors have more critical sense of all the other important aspects of the patient. As well, in this study we analyzed the algorithm that detects only diabetic retinopathy, but there are several algorithms even included in this study that can detect up to 20 different eye diseases. So this is the way of work in the future as well.
Thank you for your work, and I want to say that it's excellent done, this data analysis and your systemic review. It's nice work. Thank you.
Thank you for that.
So I would like to thank all the presenters for their delightful presentation. And now let's take a 7 minutes break while all the scores are counted. And right after the break, we will announce the winner of the session. would like to thank the jury for their work today. Therefore, after counting all of the jury points, I'm delighted to announce that the winner of the session is Violeta Vintortaitė, with the topic MIR-TOO, a 3P expression in the serum of a patient with Parkinson's disease. Please come to the stage. Congratulations.
Thank you very much.
This is your gifts.
Thank you, I cannot do it.
So the neurosciences session has finished. I would like to thank all the participants for attending the 6th International Health Sciences Conference. Hopefully it was interesting, and now I invite you to join the rest of the conference and come to listen to the keynote speaker today, Associate Professor Dr. Vincas Urbonas. So thank you all for your interest in science, and have a good day.
you.